Hey, this is just a quickie one. And I'm just going to follow up on what you just read about because it's just a question I always get. And I think it's a good context for starting to introduce you to some issues that you're going to run into as we go through the course, basically. So the question is always, what is the difference between a psychiatrist and a psychologist? And quite often, I think students they're interested in psychology, and some are interested in helping others, helping people who are struggling. And these are two professions that seem very similar, that do that. In fact, they are not similar. They tend to be pretty complementary, and that's the point I want you to get as we go through this. So let's start here and just simple list. What are the differences? So right at the top here, the first difference is really the path to becoming one of these beasts or the other. Psychiatrists are doctors first. So before they can even think about becoming a psychiatrist, you have to become a doctor, a medical doctor. So you first, do whatever undergraduate you need to get into med school. Then you do your med school. You become a full-fledged doctor. And then after that, you can spend another 4 years doing a residency in psychiatry. So in those 4 years, you learn more specifically about the psychiatric practice, which is a lot more about the brain and how the brain works, and especially so-called neurotransmitters in the brain, chemicals that the brain uses to communicate within itself. And sometimes when these chemicals, well, I should say it this way, sometimes in some mental disorders, these chemicals seem to be out of balance. And so you kind of learn the linkage between neurotransmitters and certain potential mental health kind of conditions. All right. Psychiatrists, on the other hand, do a bachelor's degree, and then they do a psychology PhD. And so, at that point, you are technically a psychologist. So I am technically a psychologist because I have a PhD in psychology. However, what's not mentioned here is that usually you follow that up with, you would either do graduate work in a psychology graduate program, like the one we have at UTSC, a clinical program, I should say. Or you could I could take some courses, and I could take a test, and I could become a clinical psychologist if I wished. I don't wish. I'm not a clinical psychologist. So I'm just a normal psychologist. But it's very different approaches. So the psychologists learn a lot about psychology, including some of the things you're going to learn about throughout this course. A really important one, two important ones, are the behavioral psychology chapter, where we'll talk about how rewards and punishments can change behavior, and the cognitive psychology chapter, where we really learn about the mind and how the mind and the body interact. And so psychologists know that really well. They know the psychology side. Psychiatrists know the biology side, really, the much more medical approach. Okay. Now, once they have this training, let's just go down the psychiatrists. They mainly somebody comes in and they try to figure out what disorder this person has. And they use something called the DSM-3, or the DSM, what are we up to now? 5, something like that. The Diagnostic and Statistics Manual, to kind of categorize somebody, talk to them for a while, and figure out what sort of disorder they seem to have. Once they figure that out, they can prescribe drugs. They tend to work within hospitals, and they earn lots of money. So, this is really their main approach to things. It is kind of like, okay, if you have a certain condition, then that probably means that if I gave you this drug, it would make you feel immediately better. And that tends to be the approach, and so they're continually titrating drugs. We'll talk about that a little bit, but it's really drug-based therapists. Psychologists, of course, did not go to med school, which means they don't have the right to prescribe drugs. Instead, they tend to use therapy a lot more. They tend to use either talk therapies, especially talk therapies, or various other approaches to help the client, the patient, kind of learn how to take control of their situation. So let's talk about this a little bit now. So their main duties involve supporting people by providing psychotherapy. They can't prescribe drugs. They don't work in a hospital, often it's private practice, and they may earn less than psychiatrists. Who cares how much people earn, right? I want to give you a clearer sense of this. So I think you got this from the textbook, but I wanted to just follow through and use an example to make this all a little bit more clear. So let's imagine this is somebody who's suffering from depression. And of course, the real problem with depression is people start thinking their life has no value, nothing good will ever happen to them, existence is meaningless, and that can often lead them to suicidal thoughts and suicidal behaviors. In fact, depression is the most dangerous mental disorder because of that, because so many people who are depressed ultimately kill themselves. So imagine this is you or somebody you love that's at this point and you're very worried. Let's say somebody you love and you're very worried that they may harm themselves, and so you want to seek help. If you go to a psychiatrist, they will do the sort of following analysis: that we know that there's this neurotransmitter, this naturally occurring drug in the brain called serotonin, and we know that when there's positive mood states, there's a lot of serotonin. Negative mood states, there's not much. So we can give a drug that increases the amount of serotonin in the brain. For those of you guys who've had experience with drugs like ecstasy or other things like that, that's essentially what they do. And the result is the person feels better. Okay, you give them the most common ones now are what we call serotonin reuptake inhibitors, which means serotonin is released by some parts of the brain, and then when it would normally be taken back up, it's prevented from being taken back up. So more serotonin ends up existing, and that makes the person feel good. So as a short-term solution, the drugs can work really well. And that can be very important. You know, if this person is feeling suicidal today and we can get them out of that mind state, that may be what keeps them alive. The problem is, well, there's really two problems. I've really laid out one here, but I'll mention the second one. The problem is the brain is not a static device. You can't just add a drug like you're topping up oil. If you do something that affects its operation, it will change its operation. It's very dynamic. And specifically, if you're doing something that's producing more serotonin in the brain, it will sense that at some point and it will produce less serotonin naturally. It's almost like that state it's at was the state it wanted to be at or whatever. And so if you're causing more serotonin in the brain, it'll react and reduce the amount of serotonin, which means you then have to up the level of the drug. And you can continue doing this, you know, having to increase the level of the drug and increase the level of the drug. And so what we have is this person really relying on this drug and needing it a lot. And if we ever take it away from them, they're going to go way back to that depressive state. So, you know, that's a problem. The other problem is, of course, and I don't mention it here, but I should have, is side effects. Any drug that we have often has the effect we want, in this case, enhancing mood, but it sometimes produces all sorts of other effects as well that the person doesn't want. And so you may have to put up with weight gain, for example, or you may have to put up with constant feelings of anxiety, being on edge all the time, or something like that, because your medicine produces it. So you don't feel depressed anymore, but you have these other things to deal with, okay? That's the sort of drug approach, and this is why it's not, you know, most people say this is not the, you know, panacea. This is not the best way to do things. Well, let's contrast that with a psychologist. What would a psychologist do? Well, it turns out that when we're feeling depressed, our attention to the world becomes biased. We start overblowing negative events. And thinking about them all the time and worrying they're going to happen again. And so our mind really becomes fixated on negative events. And then if positive things happen to us, we might not even notice them at all. We don't think about them at all. And so we're paying a lot of hyper attention to negative things in our life, minimal attention to positive things. And of course, this is feeding this mindset that life is horrible and everything's terrible. That's a habit of thought, a habit of mind, to do this biasing thing, and habits can be changed. So, you know, let me give you a concrete example here of a very simple thing, and there's a bunch of approaches to this, but a very simple thing might be to ask a depressed person at the end of each day to write down 3 good things that happened during the day. And they know they're going to have to do this all day, right? And so now as they're going through the day, they have in mind, oh, later tonight I'm going to have to write 3 good things, so I better, pay attention, see if there's any good things that happen. And this person doesn't want me to write about any negative things. They only want me to write about good things. Okay. And so then they go through their day, and every now and then a good thing happens. And the idea would be they would hopefully say, oh, that was kind of a good thing. Normally it would have gone right by them, right? But they say, okay, that was normally a good thing. I better remember it for tonight. This is one of the things I can use. So let me make sure I think about this a little bit more deeply. And so what are we doing? We're getting their attention more towards good things, and we're getting them to think more about those good things. And then a second good thing happens later in the day, and a third good thing happens later in the day. And then they're able to write us about those things. But we're creating a new habit where we're pushing their attention towards good things and pushing their thought processes towards good things to counteract that negative bias that they had. Now, this takes effort. It's a skill, right, to do this, and it takes practice and time. It's not a quick fix. And that's the real distinction between these two. In fact, I told you they were complementary. It's become very common for psychiatrists and psychologists to work together. What we would likely do in this situation is if somebody was suicidal, we would, in fact, give them a drug that would help their mood state. If we can get their mood state okay, then we can start doing some therapeutic interventions with them. So we can use the drugs to keep them at a point where they can actually benefit from therapy and get through it. And then the hope is, as the therapy starts to work, as their attention process start to change, then we can wean them off the drug. And so the hope is, at the end, you don't want the drug. And in fact, you hope you've developed skills where this person will just be okay going forward. But the drug can get you through that immediate tricky period. And then the therapy can make it a longer lasting solution for this person. This is the common way these two professions interact now. As working together with a patient, sometimes having a team of medical professions helping them, monitoring their progress as they go through, a team that includes both a psychiatrist and a psychologist. Okay, I thought that example just might make it a little more clear for you. Later, guys. Next time.